Hi, everybody, and thank you for so much for joining us tonight for our very first webinar, When Kids Get Sick, A Parent's Guide to Virus Season. Before we dive in tonight, I just wanted to start things off with a couple of housekeeping items. So just to let everybody know, this meeting is going to be recorded. Right now, we can't see your faces, but we and others that have joined tonight can see the name that you registered for the webinar with. So I just remind you to keep that in mind when it comes time to participate in the Q&A if you have any concerns about privacy. Speaking of the Q&A, you can ask questions in the chat box that you see on the screen. It's either to the top of your team screen or on the right-hand side. You don't need to wait till the end of our presentation. You can ask them at any point this evening, and we will try to answer as many as we can, both during the presentation and spend some time afterwards as well, wrapping everything up. And my final note for this evening is just a reminder that tonight is all about education, and this presentation is definitely not a substitute for in-person medical care that you would receive, whether that's in the emergency room, at COPC, or from your family doctor. Tonight is really just about empowering you guys to feel more confident when caring for your kids and their symptoms at home. So now I'm pleased to hand things over to Dr. Leifso and Dr. Acker. We'll start off with Dr. Leifso, our pediatric infectious disease specialist, who's going to take us through some kind of baseline education about viruses. And then Dr. Amy Acker, who's the medical director for COPC, is going to talk to us about how to manage symptoms at home and when you really should make the call to come to the hospital for help. So over to you, Kirk.
Thanks very much, and thanks very much for joining us. I guess I just wanted to start by orienting us all to what viruses are and talk a little bit about the ones that I suppose we're concerned about. But just to start off by what is a virus. So viruses are extremely small little biological particles that are made up of genetic materials, so RNA and DNA, and they're surrounded by a protein coat that keeps it all together. They can't make copies of themselves on their own, so they require the help of a host cell. So they infect that cell and then replicate and carry on. And not all viruses are able to infect all organisms. They have some viruses will only infect a particular organism, like humans or a different animal, or bacteria or plants. Some can kind of jump over and mutate and evolve, and that's where we get some things like influenza or even SARS-CoV-2 that have jumped over from animal to animal. So some viruses have cause infection and then resolve and go away. And some viruses, like the cold sore virus, infect you and stick around for years or your entire lives and can come and go. But most of the viruses that we're going to be talking about today are respiratory viruses that come around and then resolve and don't stick around with you, but can cause you problems when they're there and can reinfect you later on. So they enter in a cell, like the cells in the lining of your nose or the cells in the lining of your airways. They reproduce themselves and then package themselves up and are released either to infect surrounding cells and move along in an airway, or to be expressed from your body. So they can go on and infect somebody else or come into contact with somebody else and try and infect them and reproduce themselves that way as well. What is it about September and October and the winter that we worry about? And that's just because there is some seasonality to the respiratory viruses. There's about 9 viruses that are responsible for most respiratory infections. And some of them you might have heard of, and some of them you might not have heard of. So something called RSV or SARS coronavirus 2 or other human coronaviruses that are related but don't cause the same sort of disease. And influenza are 3 that you probably have heard of and that usually come around and might be considered to be wintertime viruses because they tend to have some seasonal spikes over the winter time. There are a lot of others, this thing called adenovirus or parainfluenza viruses, something called human metapneumovirus that comes along a little bit with RSV. It has tended in the past to be more springtime, but can pop up throughout the year. And rhinovirus slash enteroviruses. And rhinoviruses cause colds all year long. And does it matter? Well, I mean, all children have had, say, for RSV, have had at least one infection by their second birthday, if not more, from RSV. With rhinovirus, most children have on average 2 infections with rhinovirus every year, and it causes around 2/3 of the common cold. If there's a community outbreak of influenza, then the highest incidence of influenza usually happens amongst children, particularly those who are in school ages, and spread within families and close contacts is pretty common. That human metapneumovirus, which you might not have heard of before, but it's pretty common. Most children are infected at least once by their 5th birthday, and hospitalization rates or severe illness from that can be comparable to influenza and another virus called parainfluenza, which is commonly associated with croup. If you are a parent of a young child, you might be familiar with croup and what that looks like. So, all of these viruses can cause respiratory tract infections, and they can cause symptoms and can be severe. And RSV, influenza, and human coronaviruses have these clear peaks, but those other viruses can be spread year-round. And we've seen this both in the hospital and in the outpatients, where rhinoviruses and enteroviruses are causing, some infections even through the summer. And that seasonality and the numbers of people who are infected depend on the type of virus, and they depend on whether or not that virus has changed, sufficiently in the meantime. Influenza is a good example of a virus that changes and escapes immunity and comes back and can infect you over and over. RSV doesn't change so much, but immunity to that is not terribly long lasting, meaning that you can be infected multiple times, but the subsequent infections tend to be less severe. So how do viruses pass between people? Well, it depends. This is not all of the ways that viruses are transmitted. Certainly there are some that are transmitted through, say, mosquito bites or ticks or through food. But for the respiratory viruses that we see in children, the primary modes of transmission are these with close contact between people, some indirect or direct, so on contaminated hands or on high-touch surfaces where the virus can stay viable on, through direct kind of contact with larger aerosols, and then through aerosols through the air at short range or at long range. And different viruses in different circumstances have kind of different predominant modes of transmission. And for much of the childhood, respiratory viruses, the predominant mode of transmission is through close contact with some contaminated surfaces like hands, and through sharing of droplet spray. There is some aerosol, more long-range transmission for sure, but the predominant mode of transmission is through close range or close contact. And whether or not a virus is transmissible depends not just on that mode, but also on other factors like temperature changes. So when the temperature drops, or the humidity is different, humidity is dropping, or if there's lots of sunlight or less sunlight, then the ability for that virus to move around in the environment changes. The infectious dose, so the amount of virus that somebody is giving off, affects its transmissibility and the droplet or aerosol size, as well as the host factor. So if somebody is susceptible coming into contact the first time, or if they have an underlying reason to have a problem with their immune system, and perhaps they can't handle the initial inoculum, the time they first see the virus. And then human behavior, right? Being at home, school, the workplace, the hospital, parties, close contact, social behavior, hygiene practices like whether or not we're washing our hands really well, all affect the rate of transmission, particularly in children. Some people will ask, how can you tell these respiratory viruses apart? And to be honest, you can't most of the time. All of these viruses can cause infections in most of the respiratory tracts. Some are more common in the upper and some are more common in the lower or classically associated. So, for example, parainfluenza is classically associated with croup, but RSV can cause croup. SARS-CoV-2 infection can cause croup. It can cause ear infections. Influenza is probably the one on the list that is most commonly associated with fevers and muscle aches and pains. But it is really difficult when you're just looking at the child in front of you with their symptom list to know which particular virus is causing the infection. The severity of infection is usually related to age. So RSV causes significant problems for children in the first 12 months of life. Influenza, hospitalization rates are as high in children under 5 as they are in older people over the age of 65. But children under the age of 2 are certainly at higher risk of severe influenza and hospitalization. Rhinovirus, again, can cause asthma exacerbations, ear infections, and sinusitis. So it's actually pretty difficult. And all of these viruses can cause significant illness, but for most children who come into contact with them, particularly those who are of school age, the infections are mild. So the question about how to either protect your child or protect yourself from these infections can come up. And the question is almost not if you'll be infected with some of these things, but when. Respiratory viruses have been around from time immemorial and will continue to be with us. The immunity from an infection it can be short-lived, at least for mild symptoms. But the best way to protect yourself and your children is through immunization, particularly for influenza and for SARS-CoV-2. But influenza in particular, there is enough year-to-year variation that seasonal influenza vaccination, which should be starting in Ontario at the end of October, is really important to keep those children out of hospital. For SARS-CoV-2 or COVID, at least a primary series for a child who has not yet been vaccinated is recommended. And then other hygiene or non-pharmacological measures, cleaning of high-touch surfaces, and fastidious washing of hands with soap and water if they're soiled or have lots of mucus on them, or with alcohol-based hand sanitizer if soap and water is not available.
Thanks, Kirk. So we do have one question in the chat that I think you're well suited to answer. You've touched on it a little bit, but can kids get the COVID vaccine and flu vaccine at the same time, or should they be spaced out, for example, 2 weeks apart? And if they should be spaced out, which shot should be prioritized first?
Good question. They can be received at the same time. You don't need to delay. They can be given at the same time. And if there is a delay between, you don't necessarily have to wait for a defined 1 or 2 week period of time. They're inactivated vaccines that can be given anytime, really. But opportunity is probably the best time. You know, if you give them at the same time, then the needles are given at the same time. The pain, kind of the suffering, is all in one visit as opposed to being spaced out over multiple visits.
We're going to answer another question here with Kirk and then move on to Amy, and then we'll get to all of your other questions at the end, just because we do have more presentations to get through. But another question is, for a child under 1 year, which flu and COVID vaccines are recommended?
Yeah, so the influenza vaccine is recommended for children 6 months of age and over. And that for the first series or the first year is a 2-dose recommendation. So 1 dose and then a second dose of the influenza vaccine 8 weeks later. For children who are 6 months or older, then the recommendation is for Pfizer with a primary series. First 2 doses spaced 8 weeks apart as well.
Thanks, Kirk. I see that we have many more questions, but I'm going to move on to Amy, and then we'll come back for a more in-depth Q&A at the end.
Great to have everybody here, and I know this can be a tricky time sometimes because it's also right around bedtime. So thanks for taking time out of your day to join us. So we wanted to move into a second part and to talk about, what do you do once your kids do bring home these more common viral illnesses? And so just to sort of mention that a lot of the care for these illnesses can be done at home. And most of the time when kids come to see us at the Children's Outpatient Center, we talk a lot about supportive care. So just trying to manage the symptoms and depending what they are, doing things to help alleviate those. Remembering that babies and young kids can't blow their noses. And even when they're learning to, maybe they're not super good at that. And so having a congested nose can make kids pretty miserable, but also leads to breathing troubles and makes their cough worse when they lay down. So saline flushes for their nasal congestion. So a lot of people use, I call it the yucky sucky, but when you suck out versus just the bulb or the saline drops to go in. So all of those things, but just remembering you probably need a good amount of saline if you're trying to open up a blocked tube. Things like trying to elevate the head of the bed or crib, again, if you have a lot of upper respiratory tract congestion. Humidified air, often I'll say put this shower on super, super hot, let your bathroom get steamy. Sometimes that just loosens secretions so that they can be a little bit easier to pass. We see a lot of people who will come to COPC who maybe haven't tried medication for pain because their child didn't have a fever. And so if they are having sore throat or ear pain or are not verbal, so not able to tell you what hurts, but just seem pretty miserable, it's pretty much always okay to try a dose of acetaminophen, which is Tylenol or Tempra, or ibuprofen, which is Motrin or Advil, just to see if that can help them feel better, even when there's not fever. And then always, of course, increase rest, lots of cuddles. And so what's tricky is that there's really no medications to stop kids from coughing. And for whatever reason, coughs are always worse at night. So it's something to do with sort of laying back any upper respiratory secretions. And in fact, coughing then is a good thing. That's your body's way of trying to prevent stuff from getting into the lungs. But, it can be problematic when it's interrupting sleep, when sometimes kids will cough so much it'll lead to what we call post-tussive emesis, so vomiting because they're coughing so hard. There's been a couple of studies that have looked at for kids above the age of 1 trying honey, and for some kids that can be helpful. There was a study looking at the Vicks Vapor Rub, and again, sort of anecdotally, for some kids that can maybe provide some symptomatic relief. Cough suppressants shouldn't be used for kids under the age of 6. And, there's really not good evidence that they work in young kids and that there is potential harm and side effects. So typically we don't recommend trying a cough suppressant. When kids are feeling crummy, we want to monitor their hydration. So we're looking for at least 3 wet diapers or pees in 24 hours. And it's really typical when kids are feeling sick that they lose their appetite and don't feel like eating. So even if over 5-7 days kids aren't eating what they usually would, as long as they're drinking and peeing, and sort of we're really working on the hydration angle and trying to encourage them to drink, often when they're feeling well, you'll notice their appetite will really come back. Again, just to echo what Dr. Leifso said, the majority of illnesses that we see in kids are going to be viral, and that these viruses have been around forever. Our bodies have great ways to manage them on their own, which is our own sort of immune system. And there's no cure for these viral infections. They really just need time. And so that supportive care is what we're doing to sort of help our kids while we're waiting for the immune system to help fight off those viruses. Lots of times we have parents wondering if antibiotics would be helpful or if they're needed or if that will help them get better sooner. And so again, just to remember that antibiotics aren't a cure for a viral infection. and aren't going to make their kids better unless there's evidence of a secondary bacterial infection. So perhaps they had RSV or influenza, and now they have a secondary ear infection, or they've got strep throat. So very specific things where antibiotics will be helpful, but the vast, vast, vast majority of these frequent illnesses that kids get tend to just need time. We take a lot of questions about fever. Again, fevers make kids feel really unwell and uncomfortable, and people always want to know if they're dangerous or what's too high. In my books, I think of a fever as anything when you have a temperature that's 38 degrees Celsius or above, or 100.4 Fahrenheit. And again, to me, I actually think of a fever as a good sign. It tells me that the immune system recognizes there's a germ, it's trying to fight it off. And so a fever is in fact very common. And so treating a fever, Katie, I'll answer yours right now as I'm chatting, is really just to help kids feel better. So say they had a temperature of 38.2, they still were drinking okay, they were playing, sort of seemed like their usual self. You actually don't have to treat the fever. Typically, the higher the fever, the crummier a child feels. So, for me, it's more based on comfort, because if they were 37.9 and just seemed miserable, I would tend to give a dose of something at that point, wondering if, that fever's creeping up, you just feel really uncomfortable. So it's more about the symptoms rather than the specific number. The other thing to remember is that when we give acetaminophen or ibuprofen, it may not always make the temperature totally normal. So it might bring it down by 1 or 2 or 3 degrees, but they may still have a temperature, but be down from 39.5 to 31.2. And that, again, doesn't necessarily mean that something is really wrong. So the medicine is sort of working to bring it down, but it might not be normal. And the degree of fever doesn't tell us whether it's a virus versus a bacterial. In fact, you could have a serious bacterial infection with minimal fever sometimes, and you could have a super high temperature from a virus. So the level of temperature doesn't help predict. But again, it's really about treating the symptoms. I wanted to say one other thing. Oh yeah, so on the packaging for these, often they may give sort of a weight-based versus an age-based. And probably most accurate is to use weight-based dosing, because there are some kiddos who may fall out of a typical age, their weight may be out of their typical range for that age. And so more important, so perhaps the temperature might not be falling as much as a parent would hope, because they could be underdosing a little bit. And so we have some resources for you at the end. And some of those have some nice references where you can sort of put your child's weight, and it's going to tell you different options for the medication dosing. My last little piece to say is, this is my analogy that I talk about, is that our immune system is kind of like a bookshelf. And so when babies are born, I think of it as there's some borrowed books from the library. So these are antibodies that cross from the placenta that were maternal antibodies of things that they've been exposed to. These are temporary. They hang around for the first 4 to 6 months. And, often babies, when they don't have a ton of older siblings, may not have, very many illnesses in those first few months of life because of this sort of temporary immunity. So then those antibodies are sort of gone. Kids start to explore the world through their hands, which is what they do, everything in their mouth and hands on everything. And so then each new virus that they encounter, I think of as a book on your shelf. And so given that we know there's hundreds of viruses and all these different strains, each one is a new book on the shelf. And so in some ways, our goal of we're building that immune system is to fill up the shelves. Some kids seem to do that a lot faster than others. And again, sort of pre-COVID-19 and pandemic, there were studies that showed that many healthy kids still had 5 to 7 viral illnesses the first season they went to daycare or school, if they didn't go to daycare. And that could mean even 2 illnesses per month. And if each one can last 7 to 10 days, that could be up to 20 days a month where the kids are unwell. So it can just feel like it's back to back to back, and then that's abnormal or too much. But in fact, and some seem to squish them together faster than others, but that is still in the sort of range of normal, that it's more bad luck than anything, as opposed to a sign of a bad immune system. I'll stop there. And McLean, I don't know if there was some questions.
Yeah, so I will direct a few towards you before your final segment, and then we can wrap it all up at the end. I'm actually going to combine two questions. So one person has asked if you have any particular saline recommendations, and then another has asked about the use of over-the-counter nasal sprays, pardon me, for children who develop inflammation after a cold that doesn't subside. Do you have any recommendations or thoughts on those treatment options?
So in terms of nasal saline, to me, whatever when you can get in your child's nose. So when you go to the drugstore, there's like a quarter of an aisle dedicated to stuff you can squirt in noses. And so there's mists and sprays and infant and children, and it's all salt water. It's all very similar. So, I think if we're imagining that we're trying to unblock a piped tube, something that has a little bit more power, but whatever you can get in. So, I'll have some people will say that some sting more than others, but most kids certainly don't love this going into their nose. But it, for most children, is really helpful to help clear out that nose when they can't do it themselves. The second question was about sort of nasal sprays. And so again, there's different types of nasal sprays. So some are like an intranasal steroid, like I think you mentioned Flonase in that, or prescription ones. And so if your viral symptoms had passed, but you continued to have features of sort of nasal congestion and kind of sneezing and runny nose and things that perhaps could have been allergic or are post-viral, there are times when an intranasal steroid could be helpful. There's nasal decongestants, which typically in young kids, again, we wouldn't use, perhaps in some of the older school age kids for a very short period of time. The problem with those is you can get a bit of rebound. There's a fancy word for it, but where your nose will run more when you stop using it. So again, for very short symptom relief in a kiddo that's above the age of 6 and nasal decongestant, but saline is probably your best bet.
Another treatment related question that just came in, do humidifiers pose more risk than benefit, and do they help with congestion for babies?
Well, I'll start, and if Dr. Leifso wants to jump in, he can. So I think there was some fairly strong literature that suggested that humidified air, really its job is just to loosen secretions and maybe make it easier to pass. There had been some case studies where they showed that, if you weren't maybe caring for your humidifier in a great way, or that it could become a little spot where some infection could come from, like molds and those sorts of things. But I think if you're caring for a humidifier, and that you change the water and kind of keep it clean, that for many people, it just may help loosen those secretions. Now, it's one of those things I think is probably not going to cause any harm. And if it helps your particular child, great, use it. If you try it and you say, nah, it didn't help their nose at all, then not something you need to use.
I think I agree with Dr. Acker. For most people, even, if they're not cleaned properly or frequently, they probably won't cause too much harm other than maybe some irritation. But for people who have maybe compromised immune systems, they're not the greatest if they're not kept clean. But if you had to choose what would be probably most effective, I think, and I don't know Dr. Acker's experience, but the saline irrigation is probably quite a bit, if you do it frequently during the day, like not just once a day, but 4 or 5 times or more, especially in the young ones, before naps and things. That's probably more effective than having a humidifier in the room with the child. However, having a pretty dry home, dry air in the home in the wintertime does cause things to crust up as well too. So.
And our next question actually perfectly segues into Dr. Acker's next topic, which is when should we take a child to COPC for a cold with symptoms, etc.?
Perfect. So I'm going to move on to these, and then if I don't answer that here, then we can sort of delve into that further. And so we know it's super tricky because there are many, many people in our community that do not have access to primary care, and walk-in clinics are pretty limited. So with the caveat to say, we recognize that many people who come to COPC, to the urgent care there, is because they have nowhere else to go. However, I guess to say that if you do have access to a primary care provider or a walk-in clinic, some of the things that they should be able to deal with for a child is, if you have a child who's had a viral illness and their fever seems to be lasting a bit longer than you thought. So most times we'll say a fever sort of typical is going to be to last 1 to 3 days. So if it's lasting a little longer and you're just wanting someone to say, can you check in the ears? Can you listen to the lungs? Is there something else happening that I'm missing? That would be something that could be very appropriate to be seen through your primary care provider or walk-in clinic. Symptoms that continue to last for 1 week. Again, thinking that most viral illnesses can take up to 2 weeks to get better. If they had an earache or a sore throat with a fever and you were concerned maybe this was strep, because there's no other viral symptoms like a runny nose or a cough. If you're worried about how much they're drinking or that cough is persisting, those are all things that a primary care provider or walk-in clinic should be able to help with. Times when we think it might be more appropriate to come straight to the hospital, so either to the emergency department or the COPC urgent care. So an infant less than 3 months with any fever is someone that for sure that we want to see. In that case, we may be doing things like blood work or in and out catheter, depending on the situation. So that would be a very appropriate visit to the Children's Outpatient Center. If kids are having breathing trouble, so again, in kids, this may look like they're breathing faster than usual. They may have some nasal flaring or tracheal tugs, this little bit sort of under their chin there, sort of seems to go in when they're breathing. Retraction, so sucking in between their ribs. Sometimes kids will be noisy when they're breathing, so have grunting sounds, or stridor, which is sort of this high-pitched sound when they're breathing in, or a wheeze, which is a breathing out sound. So if there's breathing difficulty, particularly so maybe your child had a fever and you control for the fever, but they're still having breathing troubles, then that would absolutely be come to the hospital, to the emergency department or COPC. If you're trying your best for hydration and they've only peed once in 24 hours, so we've got less than 3 diapers, then that would be a good reason to come. A child who has a headache or a sore neck that's not going away once you've tried some fever medication or trying to relieve the pain. And then kids that are more irritable, like out of character irritability or sleepiness that's not responded to any medication. So those are sort of the first few examples. I'm sure we can come up with a few more as we chat, but leave it at that.
Awesome. Thank you so much for that, Amy. So in our last 10 minutes here, I think we should just dive into all of the other questions that were posed during the presentation. So some of these may be for Kirk, some for Amy. One that came in from Kathy: if I don't have a family physician, where could I take my 4-year-old for her COVID vaccine? And she has already received a primary series.
So for 4-year-olds who have received the primary series, there at this time isn't necessarily a strong recommendation to have a booster if they've completed their primary series already. The COVID-19 vaccination boosters would primarily be targeted, at least those people who should get them would be children who are moderately or severely immunocompromised, or who have an underlying condition that puts them at risk for serious or severe infections. So there's some children who have problems with their lungs, or some children who have problems with their nervous system, so they can't generate pressures in their lungs very well. And those individuals are recommended to have a booster. But a child who does not have any of those underlying risk factors for severe disease, the recommendation is not necessarily for or against. And they can receive a booster dose, but it's not a strong recommendation. As far as where to go, the best place to consider that, because under 4 we generally won't administer them, is the public health immunization clinic, which is a self-referral clinic. But to be honest, I'm not sure if they are providing coronavirus vaccines at this particular time. They're concentrating primarily on routine immunizations for children to catch up.
Thanks, Kirk. And a similar vaccine question from Jade. Is it okay for a child to get the COVID vaccine if we're not sure if they've been infected recently?
It is, yeah. So the recommendation for children who have not been immunized against SARS-CoV-2 and who you don't know if they've had infection recently or not would be just to go ahead with the vaccine series. If you know that they've been infected, then the general recommendation would be to wait for around 6 months before initiating the vaccine series. But if you don't know, there's not really any way to tell, then starting the primary vaccine series at any time is reasonable.
Thank you. Now a question from Daniel. How long would a 1-year-old be contagious? And how long should we keep him away from sick grandparents, etc.?
Yeah, so I'm going to say that that's a little bit of a hard question. We can generalize depending on the agent. Most respiratory viruses, so RSV and influenza and SARS-CoV-2, after the onset of symptoms, are low transmissibility after about 5 days, 5 to 7 days. If the symptoms have resolved, then the likelihood of being very infectious is actually relatively low. So the probably time of peak transmissibility is when they have the most symptoms at the onset, in several days after onset of symptoms. For a 1-year-old, the biggest route of transmission is actually close contact or contact with virus that has been on material, like we call that a fomite. So, a bottle or the child's clothing that they've snotted all over, or hands. And so if you want to, make sure that you have the most protection, then waiting, about that 5 days after the onset of the symptoms and making sure that the symptoms are starting to resolve. And then just making sure everybody practices really fastidious hand hygiene with soap and water. If there's lots of mucus around, because hand sanitizer doesn't really get into the mucus that well. And then if there's no mucus or dirt or grime, then alcohol-based hand sanitizer is a good alternative.
So I've got a couple questions now for Dr. Acker. Jessica's asking if you have any suggestions on viruses that have rashes as symptoms, such as hand, foot, and mouth, or similar viruses, and if anything can help that other than Tylenol or Motrin.
Yeah, unfortunately, so many viruses in kids can also present with rashes, and some have really recognizable features like hand, foot, and mouth. So we can look and say, yes, it's hand, foot, and mouth, or they have a fever, and then the rash comes a few days later and we say, oh, it's roseola. So there's ones that are super specific and we know. Most of the times when kids have rashes that are part of a viral kind of syndrome, the rashes tend not to bug them very much, aside for hand, foot, and mouth, which those mouth sores can be pretty painful. So there's typically not a lot to do for the rashes. If they seem itchy, then we can try sort of moisturizing and lukewarm bath with, an oatmeal, oatmeal or Epsom salts, and sort of just moisturizing, and a topical like antihistamine sort of thing. But the majority, again, is just the same things we do for all these darn viruses, which is going to be your acetaminophen and ibuprofen, sort of keeping them hydrated, which is probably a little bit of a bigger challenge with the hand, foot, and mouth if those mouth sores are causing them troubles. So popsicles and ice chips and sucking on a wet face cloth and whatever you can do to try and get a little bit of liquid in there.
Awesome. And another question for you, Dr. Acker. Do you have any thoughts on using Vicks Vapor Rub?
So I have no problem with that at all. Again, there's a couple of studies that suggested it maybe can decrease cough. From my point of view, it's not going to cause any harm. I have many parents who swear by it. They put it on their kids' toes under their pajamas. And so I think it's not going to cause any problem. And if for your child, it seems to help alleviate that nighttime cough, that it would be safe to use.
Right. And the last couple questions that we missed are both about vaccines. So one is it okay for a child to get the vaccine if we're not sure if they've been infected lately?
Yes. Yeah, it's similar to the answer before. So if you don't know that they've had SARS-CoV-2 infection, but they've not received their primary series, then yes, they can go ahead and be immunized. And I think that can be, there was a question about the XBB a new variant vaccine. If that's available, then they can have their primary series with that vaccine rather than the original strain.
And another vaccine one, do the COVID and flu vaccines need to be spaced out from 12-month immunizations?
They don't, no.
Right. Okay.
McLean, can I just give one little blurb about these resources that we've got there?
Yes, absolutely.
So just have a couple of links up. And so About Kids Health is a website created through Sick Kids. And so they have a health library A to Z, as well as some learning hubs and actually quite a few videos, like how to use a bulb sucker to try and clear out a nose. And so lots of videos and information there for sort of different and specific illnesses. TREC, the next one we have there, is an acronym for Translating Emergency Knowledge in Kids. And there's there's a part that's for the physicians telling us sort of first line and evidence-based management of lots of these different conditions, but there's also a parent and family section that again have some videos that explain things and give some really well laid out information. And then CHEO, the Children's Hospital of Eastern Ontario and Ottawa, also have sort of some links for resources and support that can be really helpful. So within there is where there's a nice one for dosing for Tylenol and Advil. Oh no, it won't give you access. So if you were just to Google Children's Hospital of Eastern Ontario and like parent resources, a lot of these will just come up freely on the internet. So give that a try. And then the last one there is the Canadian Immunization Guide. So that sort of if you have further questions about vaccines, then there's some good information there.
Okay. Amy, Kirk, any final thoughts or last pieces of advice before we wrap up tonight?
I mean, the final thought is that what is likely, happening this fall or going to happen this fall is likely to be the we'll see whether or not like what kind of seasonal patterns things fall into again. But it is very likely that we're going to go back to a similar pattern that we had before the coronavirus pandemic started, where we see increases in respiratory viral disease in children start coming back up in the fall and over the winter time. There are some fantastic things that are on the horizon, particularly for RSV in the next couple of years that I think will help. But just, I think remember that in the great majority of children, they'll be able to handle these infections just fine with a little bit of TLC.
Thank you so much to both of you for spending your time with us tonight. I'd also like to say thank you to everyone who joined us this evening, and we hope this was helpful for you.